Okay, good afternoon, everybody. Have to start so we can finish in time. Solve it. Just start. Okay, so the first lecture today will be Dr. Mustafa. She's professor in KU and she's a nephrologist. She was here for several years, then moved to KU. She was selected Teacher of the Year by residents a few years ago, and she's a great lecturer, and she's still coming to get this lecture every year. So thank you, Dr. Mustafa, and try to learn as much as I learned from this lecture every year. Thank you.
Well, thank you, Dr. Gohar, for the kind introduction. I tend to move, and I don't like the fact that I'm kind of stuck here for Zoom, but this lecture is meant to be interactive, okay? So please raise your hand, pop questions, ask about practical aspects to it as much as you want. And I think maybe I'll just start by saying, having worked in many programs, UMKC being one of them, it is so great that you guys get this concentrated curriculum to prepare you for what's next. And not a lot, all the credit actually goes to Dr. Gohar. So use this information, but more importantly, I think the feedback that you all give is really key because we work on making it relevant to you all. So if something comes up and you think, oh, I wish we've learned about this, and I'm more than happy to receive your feedback. Okay, so to start, we're going to talk about total body water. So about 2/3 of our weight is water, and 1/3 of that is extracellular fluid, 2/3 is intracellular fluid, and out of the extracellular part, about 1/4 is plasma, which is intravascular, and 3/4 of that is interstitial fluid. So keep that in mind every time you look at a patient, you see them pretty swollen, you're kind of trying to decide. This helps you realize the issue between intracellular, extracellular, but also intravascular, extravascular. This is the composition of electrolytes, okay? And not surprising that, you know, majority of the sodium is extracellular and majority of your potassium is intracellular. So really the numbers you will see here is what you see on your labs usually. Okay, those are the normal ranges from the lab. So it doesn't mean that we have a tiny bit of potassium. It just means a lot of it is inside the cells and so on. So just kind of keep that in mind. We're going to go and start with the first case. I have Mr. Smith here, who is a 70-year-old male with end-stage kidney disease. No surprise, I'm a nephrologist, so you'll hear a lot of these cases. Due to hypertension, and he's admitted with pancreatitis, okay? He did not tolerate enteral feeds and is on TPN. So he had a pretty complex pancreatitis history and many complications. He complains of his legs feeling weak, okay? What is the striking thing on his lap? Okay, so I have high potassium. His creatinine is 4.7. Does that bother you? No, because he has end-stage kidney disease and he's acidotic. Okay. What would you do first for this patient? Okay, you want to do an EKG. Okay, and the EKG shows peak T wave. What would you do next? Okay. You want to give him calcium gluconate, bicarb, insulin, and glucose. Okay. Especially in patients with end-stage kidney disease, but this guy was also acidotic, you know, his bicarb was low, so you never will be faulted for giving bicarb. Also, please do not forget, I can't tell you how many times we get consulted and TPN is still going, and I'm like, really? So stop the source of the kalemia right away, if you know what it is. And then the next thing, despite this patient having end-stage kidney disease, my first question to any of you, if you call us for a consult, I'm like, is he making urine? Okay, because if he's making urine, I'm thinking about the fastest way I want to get rid of that potassium outside this body. And even if I have my dialysis nurse ready and the machine cleaned and ready to roll, this patient, no matter where you are, will not be on the machine before at least half an hour. Okay, and it's almost never that the dialysis machine is ready and the nurse is ready. So I'm thinking of ways, okay, I want to get rid of potassium as fast as possible. That's why I asked about urine. Okay, so in general, hyperkalemia, there is usually a decrease in the ratio of intra to extracellular potassium concentration. Hyperkalemia depolarizes excitable tissue, decreases conduction velocity, and increases rate of repolarization. And that's how it affects the heart. Okay, this is going from down to up. This is our normal EKG, and this is what you see. You start with peak T waves all the way up to the sine wave pattern. I think the challenging part is that we know that there is no specific time. Like I can't tell you, oh, if they have peak T wave, it's going to be another hour before. We don't know that. Okay, and it's very variable, because if a patient has frequent hyperkalemia, your frequent flyers in the ER who come every week with hyperkalemia versus a patient who is hyperkalemic for the first time, okay? Is there a difference in how much they can tolerate? Okay? Okay. Why is that? Why is the patient, I'm going to repeat so it records, why is the patient with recurrent hyperkalemia can tolerate hyperkalemia better? The okay, very good. So potentials across the membrane change. Anything else? We really, there's not one theory that explains that, but it is potentially related to the potential across membrane. Some people talk about the number of receptors or the level of activation to activate the receptor. So we're not sure, but we definitely know that. However, I think having said that, it does not mean that those patients who are prone to, almost all of them end up dying from hyperkalemia, by the way. So despite them coming every time and we're so used to it, unfortunately, and I always tell them, this is what will kill you. It didn't this time. So we just have to be always conscious and careful. Okay. We worry about hyperkalemia when the potassium is more than 5.6. I do not dialyze emergently if the potassium is less than 6. So a lot, the people can tolerate that. Kidney failure is the leading cause of hyperkalemia. It can be life-threatening due to risk of ventricular arrhythmias, and it is the most fatal electrolyte imbalance for sure. Okay. Normal renal response to hyperkalemia, it does stimulate aldosterone secretion, which then stimulates urinary potassium excretion. That's how it works. Symptoms of hyperkalemia, you can have skeletal muscle weakness, paralysis, paresthesias, or respiratory failure. And the causes for it, it either is due to decreased renal excretion, so that's in the case of decreased GFR, okay? Reduced tubular secretion, so certain kind of conditions, or we have increased intake, or that there is transcellular shift, which is a lot of the hyperkalemia we see. So with metabolic acidosis, tumor lysis syndrome, and rhabdomyolysis, or that there is aldosterone deficiency or resistance, okay? And then you have many common drugs, many. Okay, I think definitely you're all familiar with ACE inhibitors and ARBs and spironolactone. Cyclosporin and Tacro are important to keep in mind, especially with your, transplant patients who are becoming hyperkalemic. You really want to check their level. Trimethoprim, sulfamethoxazole is another common one. Heparin is there. I can just tell you the main thing to know that this is heparin related. It is rare, but it does, you will see it in for sure in your career. It's typically a patient who have no issues coming to the hospital, and every time they're in the hospital, their potassium goes up. It's never, the heparin, I've never seen it cause like 7 and 8 potassium. It's usually like in the 5, higher 5, low 6. And it's when they start getting the heparin prophylaxis. Okay, so keep it in mind. But and the way to know that is stop their heparin, and you should see an improvement.
Is that for that? I'm trying to Dr. Fox wants to have the students who are on renal supply.
It is true. Although again, it's potentially there are multiple mechanisms. That's the kind of the one that's most thought of. Yeah. Okay. Yes. Excellent question. And no, it's not dose dependent. Okay, so you actually see it a lot. Again, it's really prophylaxis, anticoagulation, and you're like, okay, what do I do? Yeah. It's so funny. A lot of the patients, when I go to talk to them, when we get consulted, they will tell you like, I never had an issue. You caused this. It's in a way true. Okay, reasons for potassium to have shifted outside the cells. We need to think about it. The potassium shift to outside the cell after the blood was collected. So we can have hemolysis or tissue hypoxia distal to the tourniquet. So a lot of the time, if I'm not sure, get an arterial blood sample and check your potassium if you're not convinced that it's true. Okay. Are the kidneys excreting potassium appropriately? So think about your GFR, think about your drugs, and try to have an estimate of aldosterone level, really from all the other functions. And really, by far, this excessive dietary potassium intake contributing to problems. And it is really hard. People can do it, but it's really hard for somebody who have normal GFR, okay, to increase their potassium just because of what they're eating. If they have normal GFR, we can eat loads of potassium and we will be able to continue to have normal potassium. It's usually when they have low GFR, so your CKD and end-stage kidney disease. But even with those, a lot of the time there is something we're doing, and IV fluids and TPN are important contributors, especially in the ICU. Okay, the first thing is repeat your potassium, confirm it's true. You don't have to wait to act on it until you get the results back. Okay. If I'm thinking this is hyperkalemia, nobody will fault you to treat a critically high potassium and it turns out to be a false alarm. But you will be faulted by everybody for just waiting for the results to come back. Okay. Do your EKG stat, and if the EKG shows any changes, again, start treatment immediately. The progression of change is sometimes they just flip from peak T waves to all the way, and sometimes you can see that nice progression, and it really high, and there's no way to predict it. Okay. Hyperkalemia treatment, again, stop the potassium intake. EKG changes is an emergency. We want to stabilize the myocardium. So I asked all of you a minute ago with the case, and you almost all said I'm going to give them calcium gluconate appropriately, because you're trying to stabilize the myocardium. That's what you're doing with calcium gluconate, okay? Then you're thinking about shifting that potassium into the cells. That's when you give your insulin, glucose, beta agonists really don't work much, and sodium bicarb. So you're doing these things to shift back inside the cells, and then you want to remove it. So either Lasix or any other loop diuretic, okay? Think about medications, which we'll talk about, or dialysis. You have to remove it out of their body. And medications is really mostly works on the GI system, okay? Treatment. SPS, even without sorbitol, so that's K-oxalate, is clearly associated with an increased relative risk of interstitial ulceration and perforation, about 2 times increase in the risk, okay? When you hear 2 times increase, you get scared, but the absolute risk is really low. It's about 1 in 1,000. So it is real, it is there, it does happen. It's just not that often. And when I was doing my residency, that was our go-to medication. We used it because that's all we had, okay? Now, there is also clear that there's increased malpractice cases with using K-Exolate because of interstitial injury. So despite that being very low absolute risk, but it has implications. So people have picked this up. Okay, the consensus seemed to be avoid SBS in post-op patients, patients with ileus, bowel disease, including IBD or C. diff, obstruction, bowel obstruction, or anyone who's receiving opiate. Okay, so tell me how many of your patients are not one of these? Very few. So avoid it if you can, really. Dialysis should be done instead of SBS unless it cannot be performed promptly. Okay, if a patient is, especially for your dialysis patients, okay, really the solution is you want to dialyze them. Now, realizing dialysis is not always available, so sometimes you're just temporizing things until they get to that dialysis. Okay. Now, zirconium salicylate, Lokelma, it is not FDA approved for acute use, but it does work. It actually works, and you will see decrease in their hyperkalemia in an hour. Okay, so use it. And there is a lot of use of Viltazza, Patrimir in outpatient. So if you're in an inpatient setting, ICU setting, you have hyperkalemia, you're not sure how to treat, Lokelma is a good option. And you should see a decrease in an hour. So check your potassium again very quickly, in addition to everything else, okay, that you've already done. Questions? For Viltazza, but in an outpatient setting, it depends on why you're giving it. So if I have an advanced CKD patient, okay, and I will continue to give it until they reach the need for dialysis, you know, if they had an acute kidney injury on top of CKD, once their acute kidney injury resolves, I might be able to manage without it. Or there are times where I have to give them, you know, there's a specific medication I need to give now. So a lot of the time, I have to say, this is not ICU related, but in our practice, it helped us keep them on their ACE or ARBs or spironolactone longer, okay? Which a lot of people argue may be better for them if we can. Hyperkalemia was the main reason why we would stop. Excellent question. It doesn't work as fast. So the issue in inpatients is you're trying to find a solution for them now. They're hyperkalemic.
Like a patient sufficiently high professional.
Yeah, you can start them on Viltazza, but if this is again chronic versus acute and emergency. Okay, very good. This is just a guide, but in general, when you do membrane stabilization, so when you give them calcium gluconate, it works very quickly, okay? Really works quickly, but it doesn't last that long, okay? And the idea is, for example, something like sodium bicarbonate also works quickly, lasts a little longer, but if you are giving insulin glucose, that's not gonna work instantaneously. That's why we give all these things together. There's like a thinking behind it, okay? If I give something like K-Exolate 1 to 2 hours, Lokelma will work in 1 hour, and then diuretics within minutes, and it really will last throughout the diuretic effect. So just keep that in mind as you're planning your management strategy. Calcium gluconate will be preferred. Why?
Toxicity, we can give it peripherally easily, and chloride is more a kind of during CPR.
Okay. So it depends on the situation that you're dealing with at that moment. Okay. It's the calcium protective effect, but some of it is feasibility and easier to give. Okay, 23-year-old woman, no significant past medical history, comes to the ER with weakness, potassium is 2. So hypokalemia is defined with a potassium that's less than 3.5. Life-threatening hypokalemia is less than 2.5. Okay. Most common cause in the ED is either diuretics or malnutrition. You see this a lot with people who have eating disorders. Okay, and it should be actually an alert for all of you. Other causes, again, if you have renal losses like primary hyperaldo, bless you, magnesium deficiency, or different types of RTA. GI losses is nausea and vomiting and diarrhea, mostly them. Okay, hypokalemia symptoms, weakness and paralysis, ileus, cardiac arrhythmias, delayed depolarization, flat or absent T wave, and E wave. It's the opposite of what we see in hyperkalemia. So here, up there is the normal, and then you really go down all the way until you have, you know, the absent T wave and depressed ST segmentans, flat. Hypokalemia treatment, if the potassium is more than 2, you probably can treat orally, okay? No matter what symptoms are. If the potassium is less than 2, it's pretty appropriate to treat that intravenously. Okay. And you want to monitor the potassium values until normal values are established. Okay. Case 3. 42-year-old man brought to the ED by his sister due to hallucinations and lethargy. The sodium is 97, potassium is 4, chloride 72, and bicarbs 21. His plasma osmol is 222, urine osmolality 82, and his urine sodium is 25. What is the lowest sodium that you've seen in a patient? 102. I didn't hear that.
99.
99. 112. Didn't hear that. 105. Dr. Gohar, what's low?
I think higher than what you see, because they already managed
That's a fair statement. That's the beauty about being the attending, right? The lowest sodium I've seen for a patient who walked out of the hospital, because that's a very different story, right? Was 89. And that patient was here actually in Truman. The lowest sodium I've seen for a patient who never walked out of the hospital was 70 something. So this is really, when you're seeing these low numbers, that is, I say as a nephrologist, the one electrolyte imbalance that keeps me up at night is hyponatremia. Not hyperkalemia, because that I can order dialysis and be happy. This is the harder one. Okay, what is the most likely diagnosis? You have 4 options. What do you guys think? So the options are pseudohyponatremia, SIADH, psychogenic polydipsia, and hypoaldosteronism. Let me bring you back the case. Okay. Why? Okay. So serum and urine osmolality is low. What else? Anyone have other thoughts? Urine sodium is low, but it's not super low. Okay. So that's kind of the tricky part of this, but urine sodium is okay. The osmolality of body fluid, it's normally between 280 and 295 millismol per kilogram. Osmotic equilibrium tightly regulated between extra and intracellular fluid compartments. Water moves between compartments in response to alteration in osmolality of either compartments. Okay. Your osmolality is 2 times sodium plus your BUN divided by 2.8 plus your glucose divided by 18. So as you already can see, 90% of your osmolality is really dictated by the sodium. Okay, serum osmolality is tightly regulated. Sodium is the major determinant of serum osmolality. Sodium balance is regulated by the kidney, and serum sodium does not reflect total body sodium content. There are times when we think it's factitious hyponatremia, okay? A lot of the time, especially in the ICU, you want to see that they draw it from a line. What are the other things on a blood work that will make you think, I don't think this is true, that's likely drawn from a line? Well, you were not on the wrong track. So think about that. What else? I look at the lab, Dr. Gohar will say, you know, let's just repeat it. I don't think that's true.
It's a serum osmolarity, so no, that's not true.
Okay, but the time you had your blood, it's unlikely that you have a serum osmolarity existing already, but that's absolutely correct. Okay, what else? Okay, so I look at all the labs, exactly. And if everything is dilute, I'm like, you know, this is likely not true. The other one I found actually happened not only from the indwelling catheter, but like they drew the blood literally next to it, like so close to their IV fluid. So the nurse would swear, I'm like, no, I didn't use the line. And she's actually honest. It's just that it was so close. So sometimes that happens. Okay, hyperlipidemia. You will find normal plasma osmolarity. Hyperglycemia drives water into extracellular space and diluting the sodium concentration. The plasma osmolarity in this case will be high, okay? And then a sodium decrease about 1.6 milliequivalent per liter for each 100 milligram per deciliter rise in glucose, okay? So when I have just really high glucoses, make the correction right away. Okay, hyponatremia, either acute or hyperacute versus chronic. The chronic is the 48 hours. That's why it's almost impossible when they come to the ED to know if this is acute or chronic, because we almost never have labs that were 2 days old. You can figure it out if they're in the hospital, if it happened while they're in the hospital. Mild, 130 to 135, doesn't bother many of us. Moderate, 121 to 129. Severe, when it's less than 120, that is an emergency. And you really, really need to take it seriously. And I find a lot of the time, you know, oh, sodium is 115, patient asymptomatic. I bet you none of you in the ICU dump the patient up and walk them to really see how symptomatic they are, because a lot of these symptoms are subtle, but they're always symptomatic at that level, almost always. Hyponatremia can happen because of loss of sodium, gain of water, most common electrolyte abnormality in the hospital. Okay, most patients are stable, but if acute and severe, it can result in severe morbidity and mortality. The loss of sodium, we lose more salt relative to water, but people can still be hypovolemic. Okay, hyponatremic dehydration, GI losses, hypotonic intake, and renal losses. So chronic diuretic therapy, salt wasting, nephropathy, and adrenal insufficiency can all lead to hyponatremia. And then skin losses in patients like in cystic fibrosis. This is also something we see often with burns, okay, where everybody's like shocked. Why is the patient so hyponatremic? We can have hyponatremia from gaining water, so hypervolemia, fluid overload, especially in things like congestive heart failure, water intoxication, hypotonic fluid, and hypotonemia. I also became actually aware recently, there are obviously some cultures and potentially religions where they do a lot of fasting, but they continue to drink water. So we just finished Ramadan, we fast from water and food, but there are cultures where they actually do nothing for 10 days and only drink water. And I've seen multiple cases of hyponatremia, severe, actually lethal in them. So just be aware of what's going on with any fasting. You know, are they fasting about water? What's going on there? SIADH. So when we look at the categories, there's hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. The urine sodium, like you all appropriately looked at, really helps you. And the mechanism of action is different, and how you treat could be very, very different. So for example, when you're thinking about SIDH, okay, you do not want to be giving them isotonic saline, because that might very well make it worse, okay? However, if you know that they're dehydrated, that's what you would do. And a lot of the time, this is where there are patients who it's truly difficult to assess volume status. It is just difficult. So we understand I think the difference between somebody who's thinking about this and know what they're doing is I sometimes would say, okay, I'm not sure if this is SIDH versus that they're truly, volume depleted. And sometimes it's a mixed picture. Okay, and that happens too. I would give them maybe a liter of fluid. I don't follow them. Don't just order fluid, forget about them. If you're not sure, just have a clear plan of follow-up to, and sometimes, if the osmolality is not back and I'm not sure I really want to do something. But mixed pictures do exist as well. Okay, symptoms, a lot of them are asymptomatic, subclinical gait and mentation abnormality. The one patient who was in the 80s in Truman, I remember he actually had cerebral palsy. So everybody in the ICU said no change in mental status. And I was like, how can we even assess that? So we spoke with his sister, who she said, this guy, the minute he sees me, he smiles, and he's not smiling. That was our indication that there was truly a mental status change. So it sometimes really can be subtle. Mild to moderate symptoms, headache, nausea, vomiting, fatigue, gait disturbances, and confusion. Severe symptoms can lead to seizure, obtundation, coma, and respiratory arrest. How to treat emergency. Patient with severe symptoms due to hyponatremia, such as seizure or obtundation, those are the patients who you need to treat emergency. Patients with acute hyponatremia who have symptoms due to hyponatremia. So even if such symptoms are mild, can result in life-threatening cerebral edema. Patients with hyperacute hyponatremia due to self-induced water intoxication. Okay, even if there are no symptoms, if you see it, it happened quickly. They played a very not smart game and they drank like 5 liters of water. At the time of initial evaluation, brain herniation has been reported in such patients, okay? And the serum sodium may worsen spontaneously due to delayed absorption of ingested water. So you really have to be kind of vigilant, especially for people who have had acute intoxication of high volume of water. Symptomatic patients who have either acute post-operative hyponatremia or hyponatremia associated with intracranial pathology, you also need to treat emergently. The goals of therapy. The first goal is to rapidly increase the serum sodium by 4 to 6 milliequivalent per liter in several hours. I'm talking about severe, symptomatic, really bad hyponatremia. That's my first goal. But the increase in serum sodium should not exceed 6 to 8 milliequivalent per liter in any given 24-hour period. Good luck. It's such a hard, sometimes balance to do that. Okay, I want to correct quickly, but at the same time, I don't want to overshoot. And the problem with hyponatremia is we're always playing catch-up game. Because by the time I send the labs and I get the results back, it's at least a good half an hour, okay? And I'm gonna catch up with it. I know you have point of care and you use point of care. So that has changed how we manage hyponatremia quite a bit. So really rely on your point of care. Still look at the confirmation from the lab. Some point of care are more accurate than others, but use your point of care quite a bit in management. Why? Because the osmotic demyelination, center-pontine myelolysis, brain herniation, seizure, severity of symptom, all actually can happen if you correct rapidly. So we want to avoid that. Okay, a lot of the time we come and we find, okay, it is correcting rapidly, and now guess what? It's a patient with hyponatremia, but I'm giving him D5 water, or I'm actually, there are times where I'm giving even VD-AVP to kind of manage the situation. And that's okay. Don't overcorrect. Okay. If somebody overcorrects, and I've seen this, do you just wait and you look at them? You know, it happened. They were overcorrected overnight. Dr. Gohar comes in the morning. The patient's doing great. Symptoms good. Patient looks good. What do you guys think? Should Dr. Gohar say, leave him alone, or actually go back?
Manifestation usually comes up after a week or so.
Okay. Okay. What's your name?
Sullivan.
Sullivan. So Sullivan says the manifestation will happen after a week or so. And you said you wanted to give D5. I would still try to counter the, the overcorrection, definitely, because you will see nothing now. They might only see what's happening a week after the discharge. So you're absolutely right. Okay. You can give a hypertonic saline for those who have really bad severe hyponatremia. You're trying to correct it, usually at 100 ml bolus given over 10 to 15 minutes, and then you follow that by slow continuous infusion. Okay. Typically you need a central line for hypertonic saline. Follow BMP and serum urine osmolarity every 2 hours initially. You can give desmopressin 1 to 2 micrograms IV or sub-Q every 8 hours for 24 to 48 hours. Desmopressin makes the rate of correction resulting from hypertonic saline more predictable, okay, because it prevents an unexpected water diuresis from occurring during the course of the therapy. That's what it does. So just, I'm like, okay, I know what's going to happen. It's much more predictable because the patient's not all, on top of that making urine with unpredictable amounts. Okay. Do not use desmopressin in patients who are at high risk of self-induced water intoxication. You don't want to give them desmopressin and then a patient have some psych issues and they have access to like a water faucet somewhere. Don't do that. That's actually, you can cause more harm. Yeah. I've actually seen it where the patient had a sitter in the room, but they would go to the bathroom. They looked pretty good and they would drink as much as they want. So just keep these things in mind. So it has to be fluid restriction and that you can actually enforce. Okay. We do not typically use hypertonic saline in patients with chronic moderate hyponatremia who have mild to moderate symptoms or in asymptomatic patients with severe hyponatremia. Such patients are typically treated with either fluid restriction or with or without loop diuretic and oral sodium chloride is also now available. We also have urea sodium available, and I believe you guys have it too, right? Yeah. Okay. So there is insufficient correction or too aggressive correction. Okay, if we do insufficient correction, it can lead to cerebral edema. If we correct too aggressively, that can lead to demyelination. So acute hyponatremia is the most dangerous, okay, out of all your electrolyte imbalance. Symptomatic hyponatremia is a medical emergency. Again, be vigilant of what is symptomatic, what is not. Okay, we need to correct the underlying cause. So if it's the hyponatremic dehydration versus SIDH, I will fluid restrict. The other thing about SIDH and fluid restriction, I find that that happens. You put them on fluid restriction and they're getting all kinds of IVs and antibiotics. And so you're restricting them, but they're getting like more than 2.5 liters a day somehow. And the other thing that you can always do, call your pharmacy. 1, concentrate your IVs, and 2, ask them if you can switch anything from D5 to normal saline. Some medications you can make the switch and they will work with you on it. Okay, so these are things that you really practically have to do. The rate of correction depends on how quickly it developed. Acute hyponatremia is more dangerous. It increases the risk of herniation or apnea from increased pressure from rapid unbalanced water movement into brain cells. In general, correction with hypertonic saline is unnecessary unless there are neurologic manifestation of hyponatremia. How many of you have actually used hypertonic saline? Okay, pretty good. Have you used the tier or in the past? Okay. So you will use it. It's something that you will all use in your career depending on what you do, but it's not something that you do every day. And I think this is part of the apprehension of using it. Like, I don't know, I'm not sure what to do. If you really think the patient needs it, they're symptomatic, get your attending on board, get your nephrologist on board, and it's appropriate to use. Okay, case 4, 62-year-old woman who is intubated in the ICU, okay, and for pneumonia, you find the sodium 155. So now we're going to talk about hypernatremia. Serum sodium more than 150 is the definition. It's always abnormal and should be evaluated. It is always because of free water deficit, increased sodium intake versus retention, okay, increased serum osmolarity, and does not imply total body sodium overload. Rarely develops in those who have access to free water. It's really, we either sedated the patient and intubated them, okay, or that they, for some reason, cannot drink on their own. Most often from inability to access free water, at risk is critically ill, intubated, and urologically impaired. The water deficit can happen from renal losses, so diuretics, nephropathy with renal concentration deficit, diabetes insipidus, or there are some extrarenal losses, so vomiting, diarrhea, or skin losses. Again, skin losses very often in burn, very often. Hypernatremia, increased sodium intake or retention, so salt poisoning, rare but can happen. Exogenous sodium, so either you're giving them hypertonic feeding or saline, or sodium bicarb administration. Give me an example of a scenario of a patient you will see in the ICU, which you will see hypernatremia because of sodium bicarb administration. Why do you give, why would you give an end-stage kidney disease patient sodium bicarb? So you're talking about their aura. Okay, that rarely leads to hypernatremia. So yes, but it will not lead to hypernatremia. Okay, patients with a DKA, do you give them sodium bicarb as part of their treatment? No. So who else?
Acidic poisoning with patients that we give pearl.
Okay, so there are certain poisons.
Yeah.
But even with that, so you're giving sodium bicarb to balance that, but you're giving it orally. Okay. But even that's not common practice. And again, giving oral sodium bicarb will rarely lead to hypernatremia. We're talking about giving IV. When do you give IV sodium bicarb? We don't give it IV, no. And we, with the dialysis, I'm gonna leave that discussion. It's a little different because we're using it chronically. But when can we do that and cause hypernatremia?
Enforced diuresis, like we want forced diuresis and we administer it.
Okay, but that, do you administer it? How do you administer it? Like a drip?
I just read about it.
Okay, that will not lead to hypernatremia. Who are the patients? You all have done it, I bet you. Septic shock, severe acidosis. At what case do you actually, it's part of your protocol that you can use sodium bicarb? Other than that, codes, absolutely. All the time, you push sodium bicarb 1 amp, 2 amp, 3 amps right away. And if you check their blood labs, they all will be hypernatremic from the sodium bicarb you gave them. So just in that case, give them some time. That will correct because you induced it. So yes, so actually you give quite a bit of load of sodium when you give sodium bicarb in codes. Absolutely. Okay. Mineral corticosteroid excess or hyperaldosteronism can all lead to hypernatremia. Okay, what you need to do when you're evaluating them, you want to determine their volume status, their blood pressure, renal water loss. The kidney does not appropriately respond to hypovolemia, or is there low urine gravity and osmolality, or is there high urine sodium? Extrarenal water loss, kidney responds appropriately to hypovolemia, but then that there is high urine specific gravity and there is low urine sodium. Okay, hypernatremia treatment, treat the cause. Okay, correct volume disturbance if present, Replace free water deficit, 4 ml per kilogram, times the desired change in serum sodium. I'll talk about that in a second. Risk of cerebral edema from rapid correction. Also here, you do not want to rapid correct, okay? Hypernatremia, even when they're like, I've seen 160s and 170s, believe it or not, and they're confused. And then they usually ask me, do they need dialysis? And I'm like, no, correct their hypernatremia first, okay? However, you really do not want to do it rapidly. So give them time and correct it slowly. So typically, if I'm, asked about how to correct, if I have a patient with 160 sodium, I don't want to bring them next day to the 135. Like bring them to the 150 next day, and then to 140 the next day, and so on. Okay.
Question.
Yes.
Which patient groups are higher risk for complications from overcorrection? Are kids higher risk than adults? Hypers higher risk than hypo?
So with correction, the worst outcome can happen if you overcorrect hyponatremia. Who are the patients who are at higher risk of having complication when you overcorrect? It is really people who have more comorbidities. It depends on the rate of the overcorrection. And it is, I don't remember that there is, I want to say woman, I think there is a gender, but not huge. There's a gender variation or sex variation. And it is people also, there are certain, trying to remember, there, I don't remember, I would assume that kids would be a worse outcome just because, but I don't know that, honestly. Case 5, 19-year-old female with headache and constipation for 6 weeks with abdominal pain. She's on hydrochlorothiazide for hypertension. Blood pressure is 160/90. These are her labs. So the creatinine is 3, sodium is 140, calcium is 13.8, and the rest of the labs you have. Okay, and the lipase is 1200. What does this patient have? And pancreatitis. Okay. So you all know this: stones, bones, moans, groans, and effects on your, EKG. I really like this approach to hypercalcemia. It is from UpToDate, but the idea here is, that you want to check and repeat, confirm it. You want to do your clinical evaluation, and then you check your PTH. If your PTH is appropriately suppressed, okay, you know that it is non-PTH mediated, and you can think about, PTH related protein, elevated 125, vitamin D, and so on. So you're thinking in one direction. If the PTH is not appropriately suppressed, it's really mostly 2 options. It's either primary hyperpara or FHH. It's really simple when you think about diagnosing hypercalcemia. In an emergency in the ICU, it is very unlikely that FHH is going to cause it. So don't worry about these things. In your first concern in the ICU, you want to manage it because it can have complications, but this is the diagnostic algorithm that I find very helpful. Most hypercalcemia patients are also volume depleted, okay? Just because of the fact that they have all this calcium. Hydration to increase urine output and calcium excretion is #1 in your management, no matter what, okay? Normal saline with potassium at 2 to 3 times maintenance if renal function and blood pressure allow. Why are we giving them potassium? It's because as we're giving them all this fluid and we're actually helping the kidneys to excrete, they're going to lose, the kidney will lose potassium as well. So you don't want them to become hypokalemic, okay? Forced diuresis. You only want to start the forced diuresis when you know that you 100% have replaced their intravascular depletion. So don't order IV fluid and diuretics. Only start the diuretics after you've given them IV fluid for a while. Okay, and only when I start seeing, they're having some edema and stuff. Calcitonin is another modality. Bisphosphonate can be used, and dialysis. Okay, it's really the forced diuresis works pretty quickly. If they're obtunded, they're really hypercalcemic to the point, or they're not, kidney function is not great, so you're not able to achieve diuresis. There are times where you have to do dialysis for hypercalcemia, not often, but it happens. We'll talk about hypocalcemia. Okay, increased phosphate levels. That happens, hypocalcemia with increased phosphate levels, it speaks to chronic kidney disease, or that you're giving them some phosphate-based therapy. Okay, hypoparathyroidism, post-thyroidectomy, hypocalcemia, and these are cases that you really have to be vigilant about managing because they can go into really, really bad hypocalcemia. Okay, congenital deficiency and severe hypomagnesemia. You can maybe vitamin D deficiency, something like osteomalacia and rickets, resistance to PTH drugs, if they're on calcitonin and bisphosphonate, and others, things like acute pancreatitis, citrate, low plasma albumin, and malabsorption. I'm just going to mention pancreatitis for a second. So a lot of the time I see patients coming to the hospital, okay, they have pancreatitis, and they're hypercalcemic, and everybody got concerned about the pancreatitis and treated it. In these cases, most likely the cause of their pancreatitis is the hypercalcemia. Okay, so while you're worried in the acute phase about treating, hypercalcemia is one of the causes for pancreatitis. Causes can actually precipitate that. So don't ignore it. We actually had one case when I was in Truman. The patient was admitted like 2 times with pancreatitis, and it was only after the second admission that everybody picked on the hypercalcemia, and then it was diagnosed that she had metastatic breast cancer. So always try to find what's causing it, really. Okay, and these are some of the clinical manifestations. Again, specific physical exam finding, but it can cause cardiac arrhythmias, disturbances, and so on. It depends on the underlying cause and severity. Administration of calcium alone is only transiently effective. Mild asymptomatic cases can be replaced orally. Symptomatic, you want to treat immediately. If somebody is symptomatic from hypocalcemia, you want to treat them with IV replacement and cardiac monitoring. I'm going to talk about, there are some cases about treatment of hypoparathyroidism, but the idea here is you want to aim to keep their calcium from 8 to 8.5. You can give them oral calcium supplement, but you actually also have to give them active preparation of vitamin D, so calcitriol and alpha calcitriol. And you want to monitor the urine calcium to creatinine ratio and make sure it stays below 0.7, and you want to monitor their plasma calcium. Those can be one of the hardest cases, especially post-op, to manage their calcium. Okay, hyperphosphatemia is not an emergency. Hypophosphatemia can be an emergency. What is the one thing that you can advise? So you have some patient comes in, has diarrhea from metformin, okay, and then hypophosphatemic. What can happen when the patient has low phosphate? Why is it an emergency if it's severe? Arrhythmia is one. Muscle, which is the one muscle that we worry about the most? Diaphragm. Excellent. Because of, so that's why we want to treat it. Okay, this is true. What can you give them orally? So you treated the acute phase. The critical phase, you give them IV phosphate. A lot of the time with phosphate, you're giving potassium, so keep that in mind. You treated the acute phase. What can you advise them to do with their diet to help hypophosphatemia? What is that? Milk. Okay, they want to drink milk, but guess what? This patient is also hyperkalemic. So I don't want them to have food that has both potassium and phosphate. You're absolutely right. That's one of the trickiest situations. I don't want to give them potassium, but I really want to give them phosphate. What do I give them? Something unhealthy. Cola. So it's the only time I have actually prescribed 1 Coke a day for a patient. That's actually true. It's when they, I had a patient who had hepatitis B on medications and metformin causing diarrhea, and really the potassium is, phosphate is low, but they have chronic kidney disease and the potassium is borderline. So they drink 1 Coke a day and that solves the issue. And it has to be, it's the diet in the Coke, by the way. So if they drink 7-Up or anything, it doesn't work. You need the color. Yes.
Can it be like diet Coke or not?
It's the color. So you can give them Diet Coke as long as they're getting the color. It's in the color. Yeah. Okay, I'm gonna actually stop here. And I just want you to not forget, in general with hypomagnesemia, consider hypomagnesemia in cases of refractory hypokalemia and hypocalcemia. So check their magnesium. Treat hypokalemia and hypocalcemia first when they happen with acidemia. Again, we've seen cases, if they come both acidotic and hypokalemic, give them the potassium first. The low bicarb is not going to kill them now, but the low potassium might. Treat the potassium because once you give a little bit of bicarb, the potassium is going to drop. Okay. And thank you so much. Any questions?
So in hypocalcemia, in hypoparathyroidism, you say you have to monitor urinary calcium in ratio to vascular less than 0.7. So what's the reason? Is this the renal stone that we want to?
Well, it's partly because if you're trying to treat hypocalcemia and you know that they're excreting so much calcium in their urine, that will give you an idea. That's why you will probably adjust their vitamin D dosing and so on. So it just gives you an idea of dosing that I might not, I'm kind of running behind and so on. Yeah. You guys have been great, excellent questions. I appreciate the live and engagement in the session. Dr. Gohar, thank you.
Thank you very much. 2 years ago, we had 2 cases in the same week with iatrogenic hyponatremia from fluids we are giving with medications. One was labetalol for hypertension in D5, was getting heroic doses, and one was phenylephrine in D5. So